session on bone marrow transplantation and bone marrow failure. And it was a fantastic session thinking about if donor choice is still upwards in our mind when we're planning transplant, especially for patients with aplastic anemia. And then we heard about some novel trials and approaches to transplant standard acquired aplastic anemia, but also other inherited marrow failure disorders and the way we're advancing the field.
Yeah, the interesting thing about the donor choice issue is that we had a nice little debate because we have new data that really suggests that almost any donor, or specifically a haplodonor and an unrelated donor, have really great outcomes. But we had to contrast that with our older data, which didn't suggest that. And we talked about some of the subtleties that surround that question. You know, why is the new data so much better than the old data?
And I don't know that we got to the answer for that.
No.
But one piece of the debate that I found interesting and both helpful and really relevant for patients is everyone seemed to agree that transplant center matters. Time to transplant efficiently to keep the patient safe is important. And then really asking those good longer-term questions, because we had such a nice discussion on the late effects after transplant that we really must be mindful of, even when we have great hematologic outcomes, as we want for all our bone marrow failure patients. We want to make sure that we don't create any other problems down the line.
Exactly. I want to reinforce that again. It's important that your center is experienced. Whether you do an unrelated transplant or a haplotransplant, you want to just make sure that they're very comfortable with the procedure, that the things that make the transplant better are lined up. Your patient hopefully isn't infected at the time they're going to transplant, and some of the other things that can get in the way of a good procedure are really taken care of before you start. And then you really understand whether you want to do a transplant or not.
Right.
Because there certainly are still options. Immune suppression is still an option. And I think that one of the things that I thought was really important, because you talked a little bit about the late effects issues, I think that people need to really understand the late effects associated with the procedure they choose. If they want to try to avoid transplant, you can. You can't all the time. You can only some of the time, because immune suppression in general will work only for a portion of patients, and eventually you may have to go to a transplant even if you start with immune suppression. But transplant itself has its own set of side effects.
Indeed. And I think where we heard some of the newer science was one concern that affects males and females, especially in their childbearing years, is whether or not transplant would render them infertile. And one thought may be that the dose of total body radiation and the conditioning regimen really feeds into that issue. And so we heard about a specific regimen in Fanconi anemia that actually had the ability to eliminate radiation. We heard the same in short telomeres. And then we heard about some trials, your trial, the transit trial, and then we have a trial for upfront haplo or unrelated donor. All this new science trying to understand which pieces we need, how we're going to improve, but also really thinking about quality of life and the longer term issues with, I think, fertility at one of the utmost points, didn't you think?
Absolutely. I think that the challenge is when, with our current approaches to do haplo or unrelated transplant, we need at least a small amount, between 200 or 400 centigrade of radiation. And that amount may affect fertility. We'd all like to do it without that. You know, we'd all like to really ensure fertility. And we are hoping that some of these newer approaches that may be developed over the next 5 to 10 years may be able to, if not eliminate it, at least lower it.
And that's why participation in clinical trials really has such great value for the patients and for the field, making sure the patient and their family understand the question being asked by the trial and what it offers for benefit in the future.
Yeah, I want to emphasize the trials that you mentioned before. So the transit trial is a comparison of unrelated donor with immune suppression as starting therapy. This is a really important trial because it's going to follow everybody, not only for whether you need to get a second therapy, but also whether you are going to develop infertility or whether you're going to develop myelodysplasia or some of the later complications. We're following things really, really closely. And then your trial, why don't you describe?
No, it's great. I'll just mention one thing that I love about your trial is all the important metrics, and it's in a younger patient population.
Right. This is kids under 25.
Right, and our trial is really intended for a slightly older population. It's looking at a very specific conditioning regimen and using unrelated donors or haploidentical donors, both are possible in our trial, to understand rates of engraftment, graft versus host disease, and some very specific transplant metrics, but it is asking a very different question compared to the Transit trial.
And both of these trials are what you start with, your upfront therapy. Your trial in older adults and children as well, focusing on just transplant, but really to see how well it works and how the two compare.
And make sure we can get there efficiently
Right.
using alternative donors because, as we alluded to earlier, for the patient, time to intervention matters.
Yeah.
Whatever that intervention is.
Absolutely. So the Transit trial has enrolled 17 of 234 patients.
And we're looking for the BMT CTN 2207 to open in the late spring, probably by June or July, and really will enroll 60 patients, we're hoping, over the next 3 to 5 years.
These are really two, I think, super important trials. And we want to get them both done and get them and make sure they're successful so that we can answer the many questions we have.
Well, and we've worked together collaboratively for a long time. Some of the endpoints are harmonized so we can really give back knowledge to the field from both trials. And it's so exciting for a relatively rare disease for there to be a clinical trial option for all patients at the time of diagnosis.
Yeah.